Great. All right. So welcome everyone to our CIMTR webinar. My name is Nina Wallersberger and I'm a PhD student here at the Cambridge Institute for Music Therapy Research. Thank you for joining us today. This is our third webinar in the series this year, so we're very excited to have you. And we have Wendy Magee here from Temple University, who'll be presenting on music therapy and disorders of consciousness. And before we get started, I'm just going to introduce you to some of the Zoom webinar features if this is the first time you're using this. So firstly, as you can see, only speakers and panelists can share their audio and video. But as you've been doing, please continue to use the chat to introduce yourselves and let us know where you're from as well. And you can use the Q&A function throughout the webinar to ask questions and also upvote any other questions that you're interested in. And these will then be presented to Professor Magee at the end of the webinar. If you're using social media this evening, please use the hashtag CIMTRwebinar, and you can also follow us on Twitter at CIMTR_ARU. And after the webinar, please fill out our survey and we'll use this to inform future events. And there's also an opportunity to sign up to our mailing list there so you can find out about all of our future webinars. I'm going to hand over to Dr. Jonathan Poole now, who's a senior research fellow at the Cambridge Institute for Music Therapy Research. And he's going to be introducing Professor Magee for us today. Thanks.
Thank you, Nina. Yes, so I'm chairing on behalf of the Cambridge Institute for Music Therapy Research. At the moment, we've just finished looking at our research strategy for the next few years, and through our clinically relevant research, we are focusing on 5 areas. These include healthy aging and dementia, neuroscience and music therapy, neurorehabilitation and stroke, mental health, and children, young people and families. As Nina said, this is the third webinar in the series for this academic year, and we have had in excess of 260 registered attendees for today's wonderful lecture that we're all looking forward to. Today's webinar is presented by Professor Wendy Magee from Temple University in Philadelphia. Professor Magee has a substantial career as a music therapy clinician working with people with acquired brain injuries and neurodegenerative disorders. She worked for many years at the Royal Hospital for Neurodisability in London. It was at that hospital that she developed the Matadoc, formerly known as the Matlas. The Matadoc is a validated tool for adults with disorders of consciousness, and Professor Magee has trained people from all over the world in its use. Whilst doing these trainings, Professor Magee came to the Children's Trust where I was working with one of my colleagues, Claire Wood, and she trained us in its use. And through our conversations, we agreed with her to develop the pediatric version of this wonderful tool, which we have decided to call the Musica. So just lastly, Professor Magee has done a great deal of work in music therapy as a clinician and as a researcher. And amongst some of the awards that she has received, the American Music Therapy Association have awarded her, hopefully I'll say this correctly, the Flagler-Fultz Research Award and the Professional Practice Award for her contributions to not only professional practice, but also to research. Personally speaking, I'm not sure other people would agree with me, Professor Magee is very generous with her knowledge, her time and the support of her colleagues. And I welcome this wonderful opportunity to hear her speak about her work. So please, Wendy, over to you.
Thank you so much, Jonathan, Dr. Poole, and I really appreciate that invitation, introduction. Thank you. So I'm just sharing my screen here, hoping that all works okay. Let's just get that up. So thank you. I'm so excited to see so many names that I know here. That was really special because I must say that sitting in your living room on your own feels like you're just talking to the computer screen. So it's Lovely to see who's here. And I just want to say a special shout out to the folk from Brazil. Hola para pessoal do Brasil. Nice to see you here. And hopefully I'll see you in person next year, if the gods allow. So many of you have heard me present on disorders of consciousness and music, or on music therapy and disorders of consciousness, or on the matter doc with disorders of consciousness. But today I'm going to take a slightly different perspective. I want to think about this slightly differently, or rather present it differently. So I'm presenting material that many of you will have seen or heard before, but I'm trying to get us to think more about the theoretical underpinning of why we do what we do. This is something that I'm really passionate about, and I realize I've taught about it, but never used a particular model that I want to share with you today, so we can really move the field forward thinking about theoretical underpinnings of our work. So not just about outcomes per se, but more about how and why does music therapy, or does music work with disorders of consciousness? So I'm going to give a very brief overview to the background of DOC, disorders of consciousness, particularly awareness and why this is so important. Then we're going to think about hearing, the auditory modality in disorders of consciousness. And then specifically moving on to music and disorders of consciousness. Now we would touch on the outcomes, but we're going to look in more depth about mechanisms of change. So rather than focusing on does it work, I'm taking a slightly higher level step, if you like, and just assuming, yes, it does work. Why might it work? So first of all, I'm going to refer to this document, the guidelines, national clinical guidelines from the Royal College of Physicians, published, well, actually the latest version was published earlier this year. And just to give a few definitions, first of all, so for people who are in coma, we're normally talking about people who might be in long-term, short-term coma. I'm not going to be talking about people today in coma. So we're not talking about disorders of consciousness where the person is completely unresponsive. Rather, we're going to be talking about prolonged disorders of consciousness. People who are in a vegetative state, also known as unresponsive wakefulness syndrome, and people who are in minimally conscious state. I'll give some definitions of those in a moment, but generally the term prolonged disorder of consciousness is used to refer to disorders that have persisted for at least 4 weeks and are still under investigation. So we're thinking more here really about the acute or the rehabilitation stage. So just to touch on what the issues here are. I'm having trouble with the pictures. So we're not going to be talking about people who are in a coma, who have absent wakefulness and also absent awareness. So we're looking here at this column down here, awareness, so that they're not aware, but we are thinking about people in a VS or UWS who are awake, but who do not have awareness. And the sorts of responses we might see here are spontaneous sleep-wake cycles, no interaction to others, really important, no sustained, reproducible, purposeful or voluntary behaviors to sensory stimuli, but we might see some preserved nerve and spinal reflex responses. So we're very interested in this group here, people in VS, who by the nature of their diagnosis means that we have not been able to determine any awareness. Then we have people who are in a minimally conscious state, who are similarly awake and are demonstrating some signs of awareness. So although they are conscious, this remains diminished and fluctuating. They are, however, showing awareness of themselves and others. They're showing inconsistent responses that indicate cognitively mediated responses, not just limbic reflex spinal responses, but actually showing some cognitive processes. And also they're showing that they can demonstrate these behaviors repeatedly, really important. So they're not just spontaneous reflex responses. And in particular, we're interested in the complexity and consistency of response aids us in our diagnosis. And also the responses are specifically linked to something going on in the environment. So people who are in an MCS, a minimally conscious state, are aware, but this is variable. And then we have people who have emerged from MCS. And a couple of really important points here is that people who are considered emerged from minimally conscious state, people who are considered aware, are showing responses that indicate discrimination. And today's presentation is really thinking about discrimination, behaviors where somebody is clearly making a distinction between two things. So just a little bit about what are the main reasons for somebody having rehabilitation when they're in a disorder of consciousness. Largely, it's about medical care and minimizing secondary complications, and also how to support the family. But this is really important to music therapy, to rehabilitation, to understanding what our role might be. That one of the primary goals of for people with a disorder of consciousness in rehabilitation is to assess their awareness. And the way we assess awareness is through identifying behaviors that are purposeful and also indicate the person is discriminating. They can make a choice. They can understand the difference between one thing and another thing. So this all aids in assessment of awareness. So the videos. Now, many of you have seen the video extracts that I'm going to share. It's very difficult to gain video of people with a disorder of consciousness for all sorts of ethical reasons. The person themselves cannot give consent by the nature of their cognitive problems. And obviously, people with a disorder of consciousness have sustained a profound brain injury. They don't look like they used to look. They don't behave like they used to look. So it can be very compromising to ask family to use clinical video. And there are many ethical questions, or many questions about whether that's even ethical. So for this reason, I used video data from a documentary that was made about a young woman who came to the Royal Hospital for Neurodisability. This was back in 2001, some time ago. And there happened to be a documentary being made about her when she was admitted to the hospital. Because this is in the public domain, I feel comfortable using this video material. And this is why I use it over and over and over again. But there's always something new to see anyway. So I just want to present the first little bit of video that we're going to look at. And this is, the way we're going to think about this is about the patient, who's a young woman called Joanne, who'd had a profound anoxic brain damage. She was 5 years post-injury. And she was presenting with very complex responses. She'd been re-referred to us she'd been referred to our hospital for reassessment because her family said, well, she's diagnosed as being in a vegetative state, but we see her responding purposefully. When we tell her jokes, she laughs. When we tell her sad things, she cries. So we believe that she is not vegetative. And this is sort of the background to Joanne's case. One of the most complex cases I have ever worked with. I just add that. So what we're going to have a look at here is, I'm presenting this bit of video to give those of you who have not seen a client with a disorder of consciousness, to give you some idea of the extent of somebody's problems. And we're going to have a look at Joanne during a standardized SMART assessment. This is a sensory modality assessment and rehabilitation technique assessment, standardized. And you'll see her being assessed for her auditory responsiveness and also following a verbal, or being assessed to follow a verbal command. And the reason I'm showing this is because I want you to look at how somebody presents outside of a music condition. She's being assessed by a very skilled, very sensitive colleague of mine, Ros Monday, who was one of the developers of the SMART. So there's no suggestion here that other therapies are not as good as music therapy. I'm not saying that. I want us to have a look at how somebody is functioning outside of a music condition. So have a look at her motor responses, facial responses, how she responds to sounds, how she responds to verbal commands. So Joanne is presenting, or the way that Joanne presents clinically is as somebody who is in a vegetative state where we're seeing some responses, but we're trying to determine whether they are reflexive, spontaneous, purposeful, whether she can make discrimination, because all of these elements are ways of determining if somebody is actually aware, meaning is she in a vegetative state or is she indeed in a minimally conscious state. So, let's think about what is involved from an organic, from a brain perspective in terms of awareness. We're talking about areas of the brain that are not only functioning, but also the connections between different areas functioning. And I find it very helpful to think about people in a vegetative state who may be showing these islands of responses. However, these islands of responses don't seem to be able to connect and join up to progress to any functional response. And I find this slide in particular is a very helpful way of thinking about it, that the brains of vegetative patients show distinct losses in particular areas. And the areas that are less active in a person with a vegetative state are these two areas of the prefrontal and the parietal areas. But most importantly, it's the connections between these areas and the connections between deeper areas of the brain. So what we can see from this image is that we might have these islands of preserved function, but the connections between the different areas are broken. And this is from an article by Stephen Lorries, who's one of the world experts on disorders of consciousness based in Belgium. As he points out, awareness is related to the so-called crosstalk or the functional connectivity within this network, the frontoparietal network, and with centers deeper in the brain, most notably the thalamus. And what he observed was when we talked to vegetative patients, the activity that they observed was limited to the lowest cortical centers, the primary auditory cortices, meaning they could see activity there, they could see that the person could hear them, but the higher order centers, the polymodal areas, polymodal meaning integrating different sensory information, failed to respond and remained functionally disconnected. So this higher level response is what's important to see when we are trying to determine whether somebody is aware, whether they are actually, whether their brain is working in a way that's processing cross-sensory information and coordinating information. Now, also along the lines of awareness, there are two distinct cortical systems that are proposed to mediate conscious awareness. And the first of these encompasses these frontoparietal areas that we just looked at. And these have been linked with processes of external awareness. So particularly thinking about functions such as language processes, working memory, and attention. So external processes, this extrinsic system, external awareness. But there's also an intrinsic system for internal, or could be considered associated with internal awareness. And this encompasses mainly medial brain areas, also known as the default mode network. And these are associated with internal processes such as autobiographical memory and also emotions. So we have these two systems, the extrinsic external system and the intrinsic internal system. And what's really important to understand is that when one of these is stimulated, say the external system, that the internal system is depressed. So, and this would be in normal healthy people as well. Basically, when we're stimulated by external stimuli in the external environment, that possibly our self-awareness is depressed. And we have this reciprocal action in this way, asynchronous, really. So they work in an asynchronous way. And of course, this is particularly difficult when we're also working with people who have brain damage of the sort that we're working with in disorders of consciousness. But let's think about how sound and hearing might influence these networks, this internal and external network, these asynchronous networks. So what we know from both rehabilitation and the neuroscience research is that the auditory modality, our hearing, seems to be the most sensitive for identifying awareness for people who are in a vegetative state. So this has been documented in behavioral studies, but also in brain imaging studies. Brain imaging studies also show that preserved auditory responsiveness may exist even when the person can't move. And we could see in the case of Joanne that her movement was really very limited. But hearing may still be very well preserved. Also, higher interactions might exist between the auditory and wider cortical networks in minimally conscious patients, meaning that when we stimulate the auditory network, we might see a greater brain effect. And lastly, really important point, stimuli with personal meaning produce the greatest behavioral change and also the greatest neural activation. And this comes from behavioral studies as well as from neuroimaging studies. Makes perfect sense that if we use something that's very familiar, it's going to have greater emotional salience. So let's look at how our theoretical argument is building here. We know that assessment is really difficult. It's a really complex task with this population because of their motor problems. They can't communicate. We know they've got cognitive problems. Often people are dealing with sensory impairments as well. So assessment is really extremely difficult. However, hearing is the most sensitive, certainly for determining awareness in vegetative state. Hearing works even when there, or may be working, even when there is no movement evident. And sounds activate more areas in the brain. Meaningful sounds cause the greatest change to behavioral responses and to brain activity. And so our next question is, well, personally meaningful sounds with emotional significance starts to point to using music. You know, we know that music stimulates emotional centers very deep in our brain, as well as frontal areas as well. So if we're talking about with this population finding an auditory stimulus that has emotional valence, emotional value, as well as familiarity, music seems well situated. So we're going to come back to the case of Joanne. And many of you have seen this video extract. It's very short, 60 seconds. What I want you to look at here is to think about Joanne as we saw her in a non-music condition. Think about how she responded and performed at that point. And let's have a look how she behaves or responds or performs during music. So let's come on to thinking about looking at what the research tells us about outcomes associated with music interventions for adults with prolonged disorders of consciousness. And if you want to read a sort of review of this, I published an article in 2018 in neuropsychological rehabilitation that gives an overview of all of this research. So very briefly, we're going to look at a couple of these studies in more detail, but I'm just going to run through these outcomes that we might expect to see from using music. Music promotes behavioral responses indicative of improved arousal and attention in prolonged disorders of consciousness. It also boosts cognition in prolonged disorders of consciousness. Patients in vegetative and minimally conscious state were able to show greater discrimination to salient stimuli following music. We'll look at that in more detail in a minute. Music elicits significant cortical and autonomic nervous system activity, suggestive of discriminative ability, rather than just reflex responses, very important in our VS patients. Music may stimulate brain activation that might be able to predict patient improvement. Preferred music improves performance on measures of awareness. And this is the put forward that we're really going to look at in detail. Music engages both the internal and the external networks of awareness, facilitating awareness of self and of other at the same time. So let's look at some of this in more detail. The first study I'm going to really focus on, people hear me talk about this a lot, Julian Okelly's doctoral research that he did at the Royal Hospital for Neurodisability in London. And Julian had a look at, he had a cohort of people in VS, a cohort in MCS, and he also had a healthy control group. We're going to focus on the clinical cohorts. And what he did was he compared baseline silence with singing the person's name entrained to their breathing, which is part of the Matadoc assessment, playing them music that was known to be meaningful and liked by the patient, recordings of disliked music, and then white noise. So he had 5 auditory conditions there: silence, singing their name, preferred music, disliked music, and white noise. And what he was able to find was that using EEG measures as well as behavioral measures was that people's EEG responsiveness showed selective attention and improved arousal in relation to preferred music. So the use of familiar songs for people in VS resulted in increased eye blinks, which we believe was indicative of improved arousal, but also frontal alpha, improved frontal alpha across the minimally conscious patients. And alpha suggests that the brain is working to attend. So it's suggesting improved attention, but also across the people in vegetative state, unresponsive wakefulness syndrome, and MCS people, we saw increased frontal midline theta, which is indicative of improved moods, improved sort of emotional state, but also indicative of concentration and also memory. So we see what's most important here is that music therapy seems to improve people's, or music, preferred music, let me be very specific here, the liked music and singing people's names seem to improve arousal, wakefulness in people who are in a vegetative state, but also seem to start to recruit attention for those who were in a minimally conscious state. Now, if we can improve arousal and start to engage attention, attention processes, then this can optimize conditions for assessment of awareness for the rest of the team as well. It can help to reveal intact responsiveness. So really important finding here is that music therapy, particularly, let's be specific, not just music therapy, we're thinking today about music interventions more broadly. Music interventions using preferred music and singing the person's name may prime the person for rehabilitation. We're building our argument here. This is another study from a neuroscience lab. So a lot of the research that I'm drawing from is from neuroscience. This was a really interesting study by Castro, based at the lab of Fabienne Perrin and Barbara Tillman in Lyon, in France. And Maita, as part of her, I believe it was her master's degree, looked at having 2 auditory conditions. She worked with a group of patients, just looking here, there were 13 patients across MCS and VS. And what she did was she had a music condition where she used patient-preferred music. They established from the family what was the patient-preferred music, and they used short recorded bursts of patient-preferred music. And then they had a control condition, which was another auditory stimulus, a sound, that was shaped acoustically, just like the music. So they matched the shape of the non-music acoustic sound to the shape of the music. And then what they did was they presented in between, after each condition, they presented a list of names, 64 names, randomly selected, but interspersed in these random names was the patient's own name, again, randomly situated. And what they found was that patients showed discriminating responses more often after the music condition. That is, they responded more often to their own name after listening to music than listening to the control condition. So a really important finding, I love the name of their paper, is Music Boosts Cognition in Disorders of Consciousness. I mean, it just tells us, you know, here is the evidence. But again, let's be really specific here, patient-preferred music. We're building our case here. Now, this is one of the most important articles I feel on this topic, and one that if you're working in disorders of consciousness, I really encourage you to get hold of. It's freely accessible online. You could just search for Perrin and the title, or even music and DOC in Perrin. So the theory being put forward by Fabien Perrin, who's based in Lyon in France, is that we talked before about these 2 asynchronous networks, that when we stimulate the external network for awareness, that the internal network is depressed. So we have this asynchronous working. But what Fabien Perrin and his colleagues are proposing is that because of the properties of music, that music may engage both the internal and external networks at the same time, facilitating awareness of the self and the environment. So, listening to music, through music's properties of words, of temporal duration, involving working memory, that we're stimulating this external network of awareness. But if we're using patient-preferred music, it's actually drawing on autobiographical reference and stimulating that internal network as well. Because what we see, and this is my clinician expert evidence for you, what we see is that even in those patients who are really deeply VS, or patients who are unresponsive to other stimuli, verbal stimuli, visual stimuli, even in these patients, we often see some type of response to music. Something is going on. And we see that in this sort of change to facial gesture, or sometimes we see the localizing. So the question is why? What we're focusing on in this presentation is not does it work, but why does it work? What is the mechanism of change that's taking place? And this is where we're going to get really exciting right now. So the argument that we're building is that personal music enhances awareness and arousal, that personal music, music of personal meaning to the patient enhances cognition, that music might be able to predict emergence from VS. Personal music enhances awareness of both self and the other at the same time. So it seems that music works, but why and how? I'm just going to take a short sidestep here, because I did say in my abstract that I'd talk about pediatric DOC and music. And I want to refer to my colleague, Janine Bauer in Australia who's very experienced at working with young children and adolescents with disorders of consciousness as a music therapist. Janine's now doing her doctoral research on this, and she's just finished a systematic review that I contributed to. We've got it submitted for publication at the moment. So these are Janine's findings from the systematic review, that when we're working with infants, we don't know what music means to infants. So we can't draw the same conclusions as we might do as working with adults. It seems that exposure to music, and also when we're working with children, how do we know what's familiar? It might be more about exposure to music, or music that's presented in interaction with an attuned partner. We do know from the systematic review that infants have a higher voice or a preference for higher voices, and that less complex music stimuli may reduce the potential for overstimulation. Really important point if you're delivering live music. Existing musical skills may remain intact following ABI, and as music develops before language, music may support arousal, awareness, and cognitive stimulation in a more mediated way than language might. Particularly because we might manipulate musical syntax, thinking about tension and release, particularly to address arousal. I'm just going to keep moving because I really want to focus. This is the main slide of the presentation and our second last slide, actually. This is new material. It's not a new way of thinking for me, but it's a new way of presenting it. And I really want to encourage people to start thinking about the work, not does it work? In many ways, we know it works, and there is research that still needs to be conducted. We still need to be looking at, does music work to improve arousal, attention, and awareness outcomes in these patients? But what's really important now, both for clinicians, but also for those of you who are researchers and wanting to apply for funds, we need to start thinking about the mechanism of change underpinning our work. Not just what is it we see, but why do we see what we see? And this is my first working of this. I want to thank my colleague Helen Schumark and her colleagues at the at the Royal Hospital for Children in Melbourne. This is adapted from their publication, where they used this model, this moderating model, presented first of all by Kasdin. So let's get stuck into this. This is really the key thing about the presentation. We're talking about people, we're talking first of all about this population, okay? And we're thinking about what might it be that works. We're thinking about what's the theoretical construct to explain the change that we're seeing. But we're also thinking, so that's the mediating pathway, the mediating theoretical construct. But we're also thinking about what might be other factors that we need to consider, the moderators. These two things, the mediating variables and the moderating variables, are going to influence the intervention we present, the intervention we offer. And then we need to be explaining, well, what is it that actually changed? Not just, oh, they responded more, they opened their eyes more, they showed more arousal, they moved their hand. We need to really think about what is underlying this, what's the mechanism of change, and then the outcome. So let's break this down a little bit more. When we're working with people with prolonged disorders of consciousness in a rehabilitation unit, they are referred to music therapy because we are assessing their awareness. Awareness is founded on the person being awake and then being able to attend to stimuli. Once we have some idea of awareness, then we can actually look at higher level function, motor function, communication, and social function. So this is the reason for referral. People are referred for awareness. That's the outcome we're most interested in. So the theoretical construct that we are proposing, looking at all of that work that we've looked at on arousal, attention, Julian Okelly's work, Castro's work, Fabian Perrin's theory, and their wider colleagues, or the work they're doing, what we're proposing is that the auditory modality is most sensitive for identifying awareness in vegetative state. We also know that the auditory stimuli activate wider cortical areas in the brain. An auditory stimuli with emotional salience and familiarity elicit greater responsiveness. So this should be directing our intervention. So our intervention really needs to optimize music and auditory stimuli, sounds that have emotional salience to the individual, have some sort of emotional meaning to that individual, and also have autobiographical reference. Two factors here that we really need to be building into musical stimuli. So we need to be thinking about what sounds from that person's life are going to be meaningful. No doubt family voices, maybe sounds of the pets, maybe sounds from around their home, but most certainly music as well. What music has been meaningful, and we need to be bringing that music into the intervention that we offer. Also the person's own name. So thinking about words, sounds, names that might be most meaningful to that person. And this is what should be driving our intervention if we're working from a theoretically driven perspective. Other factors that are going to influence this are whether the person is medically stable, the level of impairment that they have sustained, and also whether they're physically ready yet to be seated upright and access therapy. Now, our intervention, what is it that's actually changing? What is it that's changing? Well, what we're proposing is that music engages asynchronous awareness networks, external, internal, simultaneously, that we're seeing through the properties of music, that we're seeing both internal and external networks are stimulated at the same time. And we're saying this because of music's ability to stimulate working memory, the fact that somebody has to actually attend to the music that's being played, that there might be language involved, so there's a language syntax being involved, and mental imagery, but also we're drawing on self-referential autobiographical material. And then we expect to see these outcomes. We expect to see enhanced awareness, and we expect to see these discriminative responses, as we saw in those studies that I mentioned earlier. So this is something new for you today. It hasn't been through peer review, so it needs a little tightening and a little bit of critique, but this is really trying to use that mediating, moderating model as a way of thinking about how and why does music work with people in disorders of consciousness. So, music interventions for people with PDOC, incorporating auditory stimuli that has autobiographical reference may enhance arousal, attention, and awareness. Music with autobiographical reference may engage both those internal and external networks at the same time. And I can hear all of the music therapists out there. Now, there are people here who are not music therapists. I know that there are some colleagues and friends who are going to listen in afterwards who are not music therapists. And I know the music therapists are saying, so we just stick on recordings of favorite music? And I can hear everybody asking that. Is that what we do? Well, what I would say is that a music therapist is very skilled at being able to deliver somebody's preferred music live, knowing which parts of the music might be most stimulating. It's going to be the parts of the music with the greatest emotional balance, either musically or, let's think about musically. But also a music therapist brings particular skills where they are able to adapt the music in the moment to the person's responses. So it's not just a matter of playing a song to somebody, it's a matter of looking at that person's responses, of listening to that person's responses and being able to incorporate those, of playing the music long enough for them to be able to respond. People may have very delayed responses. So, often I don't just play a song, I might start extemporizing on that song, bringing in the person's name, singing something about them at that moment, or just singing their name. Singing somebody's name is very powerful for this population. And we know that from the neuroscience as well. So I think, a music therapist's role here can be about building on that familiar music, that familiar self-referential, autobiographical, light music, and really extending that through improvisation activities as well. Particularly once you start looking at functional responses like communication, choice making, motor responses, social responses. So hopefully I've left a few minutes for questions.
Thank you very much. Thank you very much, Wendy. You probably can't hear everybody else, but I'm sure they are. Right, we've had a few questions. This is the first time I've done this, so I'll just try and find them.
I can see these actually, I've got them as well.
So the first question is, when we talk about prolonged disorders of consciousness, would we classify the later stages of dementia and or Parkinson's disease under this umbrella, or would it be separate?
Thanks very much, Ben. Really appreciate that really important question. So what I'd say is that the brain damage is different. A disorder of consciousness, I mean, it's, yes, very broadly, late stage neurological illness and late stage, end stage dementia would be considered a disorder of consciousness, but the pathology underlying those conditions is slightly different. But I would say that some of these premises, we don't yet have the research to really theoretically drive this, but from a clinician expert point of view, I would say some of these things hold. Singing the person's name and using music that we know has this biographical reference and is going to have emotional salience as well. Yeah, so I would say yes, go ahead with doing that. We don't yet have the specific evidence for this population, but yes. And I would also say as a clinician, just try it. Just try it and observe, make those behavioural observations.
Okay, so the next question is from Bettina Eichmanns. Do you think there is a difference in outcomes of any type or findings of assessments between music interventions and music therapy, and
Great.
why?
Yeah, thanks so much, Bettina. And sorry, I know there's a second part of that question there. So Bettina, what I'd say is I hope I answered that in that second last slide. Using recorded music, I would say if you don't have the capacity, if you don't have access to a music therapist, the thing about music therapists is A, they are the experts in delivering music interventions. That's what they've trained to do. So they have a clear idea of why they're doing what they're doing and what they're trying to elicit. Also, they will use live music. We don't have a lot of evidence, but as a clinician, I can tell you live music, more stimulating than recorded. I just say that. And what you'll see a music therapist do is they have these skills at adapting the music in the moment to patient responses. Now, we know we do this in rehabilitation. We see a tiny response, any discipline, we leap on that and respond straight away and try and build on that in the moment. We don't wait to see it a second time. Involving family caretaker, I think, is really important. Their voices are important. Also, they may be musicians. It might give them some agency in how to care for their loved one. Also, it might offer some opportunities for shared leisure opportunities. These are families who have been robbed of their loved one. You know, their loved one has been stolen away from them through the brain injury. So I think giving family any agency is a really good idea. Thank you for asking that.
Thank you, Wendy. The next question is about the use of simplicity and complexity in the music. So do you think that in addition to familiarity or preferred music, that simplicity or complexity of the music makes a difference?
Yeah. What we know from Janine Bauer's early research, that she's the colleague who's just publishing on her systematic review at the moment, is that we certainly feel that if we're working with children or youth, keeping it relatively simple along the lines of developmental needs. Rather than thinking about complexity, think about tension in the music and how we might manipulate that. I do think from just a this is just a clinical expertise, a clinical expert opinion. I do think keeping the music relatively simple. Look, we're dealing with people with a massive brain injury. Massive brain injury. Music is auditory information. They have to process it. So the question is, why would you make it really complex? You can make it beautiful. Think about the music that stimulates you to tears. Often it might be a solo voice singing a simple melody line. So complexity is not necessarily better. Think about that person has to process the information. And that's what I would go for. It might be appropriate to build up to complexity. Oh, the polyvagal question.
Oh, all right, the next question is very interesting. How do recent trends in psychotherapy towards a more embodied and holistic understanding of trauma treatment, in particular the impact of Stephen Porges's polyvagal theory, relate to music therapists and current music therapy research?
Thank you so much for this question, and thank you for sending it in advance, because it really gave me a little bit of warning, and I did a little bit of research. So I'm just going to put my hands up and say that I have heard of the polyvagal theory. I don't well understand it, but from the little bit of research that I did, you'd know much more about this, is that it seems to, it requires conscious awareness. It requires conscious awareness so that somebody can actually reason through their trauma. And I think with this population, we're trying to understand whether can they see, can they hear, do they understand? How good is their, like how much is their awareness? So I think I'm afraid I can't give any sensible answer just because it's outside the realm of working with this population, and I'm so sorry.
Okay, I think you answered another question in one of your explanations. But the question is, what if a patient is in an agitated state? Do you consider calming him or her a valid goal?
Yeah, so if somebody's agitated, you need to think again about music as a stimulus, okay? The louder it gets, the more rhythmic it gets, the more frequent, the more dense, it's going to get more stimulating. So you don't want to stimulate somebody, you want to bring them down. And it might be no music, or it might be actually using music that's going to bring them down from their agitated state. Yeah.
Okay. Dr. Street would like to ask if there's any advice for building the evidence base, single case studies, sample size, outcome measures, intervention, dosage, and type, preferred music listening or live preferred music delivery.
Yeah, so thank you for that question. Just to say that I think all the science is saying preferred music. So let's go with autobiographical meaning, relevant to the current stage. We don't have any evidence for live music versus recorded. I think that is a burning need in our profession because I have a lot of expert, clinical expertise opinions about that. In terms of design, this is a really interesting one. You know, what the experts in DOC research say is that a well-designed single subject design might be much more appropriate than randomized controlled trials, because we're dealing again with complexity of patients, and we're also looking for behavioral outcomes that are very specific to that individual. So a single subject design allows us to look for that. So I think a good sized cohort of single subject design could be important. With outcome measures, I really encourage you, if you're doing any research, to be using standardized measures, be using non-music based measures. So always try and incorporate the Coma Recovery Scale revised, it's the gold standard. But of course, I'm also going to encourage you to use standardized music based measures. And we haven't really talked about the Musica, which Jonathan has led on developing, and the Matadoc, which I worked on along with many colleagues, not just me, many colleagues had input into that. But I would really encourage those as well, those standardized music-based measures as well. Thank you.
I'm aware that we have, we've come to the end of the hour. There are 4 questions left, Professor Magee. What would you like to do?
I can type answers to those so that people have something, if I can stay on a few more minutes and do that.
Okay, all right.
Thank you, everybody. Lovely to see you all.
Thank you to everybody who attended this, this webinar. It was very interesting Wendy. It was a privilege to have you present as part of our webinar series. Thank you so much.
Thank you so much. Lovely to see you. Thanks everybody for making the time. Look at all those names. Woohoo!
Thank you, Nina, for setting it up.
And thank you, Nina, for setting this up. Thank you so much. Oh, Anna made it. Lovely, lovely, lovely.